Hi, my name is Jessica, and I'm going to be talking about how to provide early post-op care once the patient reaches the medical surgical unit. So I would have already talked to the PACU nurse and been given their information of their vital signs, how they were acting, making sure everything was okay. Then when the patient came to the floor, I would introduce myself to the patient, help them transfer from the stretcher or the PACU bed to the floor bed, make sure they were comfortable, attach their IV tubing to the wall, make sure their IV is running at what it needs to be running at per the doctor's orders. I would have already reviewed all the doctor's orders. I would make sure that the patient isn't having any current pain, and if they were, I would check my orders for what pain medications they could have, and I would administer those. I would assess their level of consciousness, assess their vital signs, make sure that they were baseline or the same as what they were having in PACU or even before the surgery. I would listen to their GI system, encourage them to take deep breaths, use their incentive spirometer, have controlled breathing just to make sure nothing gets built up in the lungs and the alveoli, no fluid, so we don't have to deal with pneumonia later on down the road. I would make sure they had on their compression stockings or TED hose, and if SCDs were ordered as well, I would make sure they have those on to prevent any stasis of blood in the legs and prevent a clot. I would check any drains that they might have from in their surgical site, monitor the color of the drainage, the how many milliliters of drainage there were. I would document that on their medical record. If they had an NG tube placed, I would check the placement of that tube, make sure the centimeters are lined up with how many centimeters they had in PACU, make sure nothing got pulled during the transfer over. I would feel their abdomen and their bladder just to make sure there was no distension, because that could not be good. I would offer them to use the restroom to monitor their intake and output. I would make sure the patient understands their doctor's orders of bed rest or how to get in and out of bed. I would help them make sure they were educated, and if they had a caregiver or a parent present, I would make sure they're understanding of how to enter the bed and exit the bed. I would check the surgical site to see if there's any drainage or anything like that, and if there was currently a dressing on it, I would check to see if there's anything on it or how long the dressing's supposed to be on there, what kind of dressing's supposed to be on there, and how often we should be changing that. I would make sure I had suction if the patient was not able to spit or couldn't control their secretions, so that way they don't choke. I would see if they are nauseous, and if they still are nauseous, I would make sure they have a emesis basin with them. I would give them water if they are able to be on water, promote their ambulation to make sure they're moving around to help prevent blood clots and increase the healing of their surgery. If they are possibly having any seizures or anything like that, I would make sure that the bed rails are wrapped and padded so that way they don't hit their head. I would make sure that the caregiver knows about that and how to take care of that. I would listen to their lungs, make sure that they're still clear, and chart everything that I've been doing. I would make sure that the patient is able to go home to a safe and clean environment. I would report any abnormal findings that I have to the provider or the surgeon, and whenever I go to leave, I would make sure the patient's bed is in the lowest position, upper half of side rails are up, and they have their call light, and they are aware of my name if they need anything.